Hello everyone, this is Dr. Nasser, and today I would like to tell you about microangiopathic hemolytic anemia, also known as MAHA. MAHA is a group of diseases in which there are two common denominators. One is low platelet count, thrombocytopenia, and two, the presence of fragmented red blood cell schistocytes. As you can see on the screen, there are many red blood cell fragments, schistocytes, that are going to be present across the field. And also, going around the field, I do not see any platelets in this field, and there are some artifacts around the field, but there are no platelets. So this is going to be repeated across the smear. However, before I move the smear, I would like to also emphasize that we have a nucleated red blood cell in here as well. Nucleated red blood cells are not supposed to be seen in the circulation in a healthy, normal individual. However, at times when the marrow is healthy and there is a severe anemia, the bone marrow releases immature red blood cells before they lose their nucleus into the circulation. Usually, they're going to indicate a response to anemia. Of course, there may be other reasons for that, but in the case of MAHA, that is the reason we see nucleated red blood cell in the circulation. As we move around this field, we do see that there is anisocytosis. Some cells are very large with polychromasia, which is indicating the patient is releasing new red blood cell to compensate for the anemia. Again, there are no platelets. There is an artifact in here of thrombocytopenia. And the presence of schistocytes and the absence of the platelets suggests that this is a form of MAHA. Now, there are various forms of MAHA present. Thrombotic thrombocytopenic purpura, TTP, hemolytic uremic syndrome, HUS, HELP syndrome, which HELP stands for hemolysis, elevated liver enzymes, and low platelets, as well as disseminated intravascular coagulation, DIC. So each one of these conditions may produce blood smears as we see in here. Of course, you may occasionally see other abnormalities, such as the presence of the target cell in here. However, the general theme that is repeated across the fields is going to be the presence of schistocytes, thrombocytopenia, and also evidence for response to anemia, such as having high reticulocyte count, having polychromasia, having nucleated red blood cells in the field. That suggests this is a form of MAHA. Now, each case of MAHA is going to be treated differently because the causative agents are different. In the case of TTP, the primary problem either is a hereditary or an acquired inhibition of an enzyme known as ADAMTS13 that breaks the von Willebrand factor, which is important factor involved in activation of the platelets in blood coagulation and blood clotting. In the case of HUS, there is the involvement of the renal system and damage to the glomeruli membrane of the kidney nephrons. In the case of HELP, is a common condition that it is seen in pregnant women, especially pregnant women who are susceptible to eclampsia, especially in the third trimester of their pregnancy. In the case of DIC, there's a systemic activation of platelet clotting factors and coagulation factors, which is going to result in the development of macrothrombi across the body. And in that case, what is going to be unique about DIC is the fact that you will also see changes in increased time for coagulation in tests such as ProTime and partial thromboplastin time, PT and PTT. You usually do not see increase in PT and PTT in other forms of MAHA. And this is the way that the physician would be able to establish a diagnosis by looking at the laboratory results as well as the patient syndrome and symptoms and indicate what is going to be the final outcome.